All right, so we'll go ahead and get started, everyone. For those of you who don't know, my name's Corey Guidry. I'm one of the PGY1 pharmacy residents, and today I'll be telling you all about the risks and benefits of aspirin in primary prevention of cardiovascular disease. So just a reminder, this is for CE credit. Make sure you sign in and complete your evaluation forms. Attendance for the entire session is required for credit, and I have no financial disclosures. So by the end of today's presentation, you should be able to review aspirin's mechanism in the prevention of cardiovascular disease, evaluate some of the primary literature regarding the safety and efficacy of aspirin for primary prevention, as well as assess the appropriateness of aspirin in various patient populations for primary prevention. So to start off with, cardiovascular disease itself is really just an umbrella term for multiple linked pathologies. You can see things on this chart such as coronary heart disease, cerebrovascular disease, and it even includes some rare pathologies like rheumatic heart disease, congenital heart disease. But in general, it's just a group of disorders of either the heart or the blood vessels. Heart attacks and strokes are really the acute events we think of most when we think of cardiovascular disease, and they're mainly caused by some sort of blockage of a blood vessel, most commonly because of a buildup of atherosclerosis. Almost 20 million people die each year from cardiovascular disease globally. That's about 1/3 of global mortality. And there are a lot of risk factors that have been seen for cardiovascular disease, things like dyslipidemia, smoking, diabetes, abdominal obesity. And these specific risk factors were actually determined from the Inner Heart trial, which was a case control study conducted in about 50 countries around the world. And it's important to note that these specific factors were consistent in all patient populations and even regardless of socioeconomic status. As far as for specific risk reduction strategies, there are some non-pharmacologic as well as pharmacologic managements. Lifestyle modifications are our main non-pharmacologic management, so things like regular exercise, diets that are either high in fiber, low in salt and processed sugars, as well as maintenance of a healthy weight and BMI, are often linked to a reduction in cardiovascular disease. Smoking cessation is a major risk reduction strategy, and aside from just cardiovascular disease, the benefits can be seen for a variety of different disease states. Alcohol consumption is actually pretty interesting. So studies have shown that alcohol abuse as well as complete abstinence from alcohol actually increases your risk for cardiovascular disease. So a lot of the evidence lies with low levels of alcohol consumption, whatever you might consider that. And then for specific pharmacologic therapies, our two main heavyweights are our statins and our antihypertensive regimens. So statins specifically, it's been shown that for every reduction in 40 milligrams per deciliter of our LDL-C, you see about a 25% reduction in CVD risk. Similar results for antihypertensives. As our blood pressure increases, about a 20 millimeter of mercury increase in our systolic blood pressure can almost double our risk of cardiovascular disease. So these medications are very important. Antidiabetics are also important, specifically in our diabetic patients. So proper glucose maintenance prevents the progression of diabetes itself, which is another risk factor as we discuss for cardiovascular disease. So for the last pharmacologic therapy, I have aspirin, and there is a question mark because as we'll see throughout this presentation, specifically in the realm of primary prevention, evidence is not really that strong, or it doesn't really have as much consensus. But that being said, about 40% of US adults over 50 use aspirin for either primary or secondary prevention of cardiovascular disease. Secondary prevention has a lot more literature supporting its use. We can all think of specific disease states in which aspirin use is indicated after an acute event. This has been shown with over 200 studies and almost 250,000 patients, the benefits of aspirin. Primary prevention, however, the evidence is really not as conclusive as I said, and it really requires a close assessment of both the risks of aspirin therapy as well as its anticipated benefits. So as far as mechanism of action, in regard to reducing cardiovascular disease risk. Aspirin leads to irreversible inhibition of COX-1. This decreases production of thromboxane A2, as well as decreases platelet aggregation and activation. So less activation of platelets, less aggregation, you would think it would have some effect on kind of those clots that we talked about. And then once again, I have another question mark. Reductions in CVD events and mortality, much stronger evidence in secondary prevention, but for primary, we'll start doing a little bit digging into the research for that. So one of the first studies I have included is actually a systematic review that looked at randomized controlled trials. These trials specifically looked at aspirin for primary prevention of cardiovascular disease. Doses were a little strange. It was shown by the study investigators that doses of greater than or equal to 75 milligrams every other day is what they considered. And they only looked at adults who are aged 40 years and older. 11 total trials were included that encompassed almost 120,000 patients, and 4 primary outcomes were examined. So the risk of non-fatal MI, non-fatal strokes, CVD mortality, as well as in general just all-cause mortality. This slide has a lot of information, but it's mostly just to show a little bit of background on all the studies that were included. So studies looking at aspirin for primary prevention do go pretty far back. We have the earliest study at 1988 in British medical doctors. A few things to point out specifically on this slide are that, especially for those 2 or 3 earlier studies, the dose of aspirin is a little bit higher than what we would consider for primary prevention. So doses of 500 milligrams a day, 650 milligrams a day are much higher than our typical baby aspirin dosage. So we have to take that into consideration. As well as the fact that only 3 of these studies specifically looked at patients with diabetes. While some diabetic patients were included in other studies, only 3 were specifically looking at diabetes. And this is important because these patients have a higher baseline risk of CVD. As far as the results, the only one of the primary outcomes that showed any significant reduction was the rates of non-fatal MI. You can see the confidence interval and p-value reported here. Non-fatal stroke, CVD mortality, and all-cause mortality did not have a significant reduction, but they did experience a reduction all the same. So the authors concluded that the beneficial effect of aspirin for primary prevention is modest. And one thing that they noticed in some various post-hoc analyses is that when we specifically looked at the trials investigating doses of aspirin less than or equal to 100 milligrams per day, the effect of the non-fatal MI reduction persisted over the course of treatment. So for all studies included, it looked like at about 5 years that effect went away, but when we looked specifically at lower doses, that persisted in our patients. So now that we've talked about the benefits of aspirin, we of course have to talk about the risks as well. Primary adverse effect, as many of you know, is major bleeding. So GI tract bleeding is really the most common, with intracranial hemorrhage being a secondary source, but much more rare. The picture here just shows a mechanism. There are direct effects as well as indirect effects through COX inhibition in the way that aspirin promotes GI bleeding. So by breaking down the mucus layer, we actually expose that membrane to the stomach acid. The stomach acid can then possibly break through blood vessels. And then, kind of continuing the cycle, aspirin's antiplatelet effect in and of itself contributes to a higher risk of bleed. So it's a very vicious cycle. This second meta-analysis that I looked at was specifically in bleeding risk. It was actually the same group of authors. They performed both of these meta-analyses for a guideline that I'll get to a little bit later. The same trials were looked at, but in this case, the trials were only included if they reported major GI or intracranial bleeding. So of the 11 original trials, 10 were still included in this trial, this meta-analysis, encompassing about 115,000 patients. The 2 main safety outcomes examined were major GI bleeds as well as hemorrhagic stroke. So as you can see here, overall, there was a 59% increase in the risk of major bleeding in all of these patients. And this is specifically looking at major GI bleeding. So this risk increase is very high in these patients. And this risk persisted regardless of whether a low or a high dose of aspirin was used. And this is a result that we'll see repeated over and over in some of the other studies we'll look at. It's usually just looking at the fact that aspirin will cause an increase in bleeding in our patients. So at which point and in which patient populations is the possible CVD mortality reduction worth having that risk of bleed? And then secondarily, for hemorrhagic stroke, the results were not as significant in these patients. So specifically for one trial, the JPPP, you can see that the top arrow, this one trial itself did have a significant increase, but it's important to note that this was a trial conducted in elderly Japanese patients, and a lot of these patients, the majority, had highly uncontrolled systolic blood pressure. But overall, when looking at all the studies, we did have a significant increase, but it was a lot more modest compared to GI bleeding itself. So from these results, the authors concluded that there's a consistent estimate in the increased risk of serious bleeding events whenever we're using aspirin for primary CVD prevention. One thing that was important to note is that the baseline estimates of our major bleeding risk in the control groups in the studies was actually a lot lower than expected. When the authors looked at a secondary study that was a cohort of about 300,000 patients, they noticed that just the risk of hospitalization for a GI bleed in these patients was almost twice that of the GI bleed risk rate that was reported in the control population. So whether it was direct or indirect, they feel like it was possible that a lot of these studies were including patients that might have been at a lower risk for bleed. So this might actually underestimate the risk of bleeding in these patients. And then just from looking at some subgroup analyses, they also noticed some specific risk factors for major bleeding, things like older age, diabetes, current smoking status, as well as elevated blood pressure. So from those two meta-analyses, they were actually specifically performed for use by the U.S. Preventive Services Task Force, or USP-STF. So this group is actually a group that makes recommendations about specific preventive care services. And this is, of course, in patients who don't have overt signs and symptoms of these diseases. Their recommendations are always based on evidence of benefits and harms of therapies, and then assessment of the balance. So the US PSTF guidelines are kind of the most frequently referenced for using aspirin in primary prevention, so that's why I thought it was important to include these. Their recommendations specifically apply for any adults who are 40 years or older, who do not have known CVD, and who do not have increased bleeding risks, and they state this specifically. Patients should also have a life expectancy of at least 10 years and be willing to take low-dose aspirin daily for 10 years. So as we'll see in some later studies, sometimes there's adherence problems that might affect results in patients. And then, of course, clinicians should really understand the evidence, but they really have to individualize the decision-making for each specific patient. And the guidelines are listed here from USPSTF. So one important thing to note is that for both adults younger than 50, as well as those who are 70 or older, they really make no recommendation for aspirin use for primary prevention. And this is really just due to insufficient evidence. For adults age 50 to 59, as well as adults age 60 to 69, they do offer a recommendation to utilize low-dose aspirin, though the grading of evidence does differ between the age groups. Of course, as patients get older, that risk of bleeding gets a little higher, so the grading of evidence is a little bit lower that the benefits will outweigh those risks. One other important thing to note is that they do want physicians to consider this only in patients who have greater than or equal to 10% 10-year CVD risk, and they specifically look to an ASCVD calculator. So we have to take all those things into consideration before we want to make these recommendations. As far as other guideline recommendations, ACCP does also recommend low-dose aspirin in patients who are greater than 50 without symptomatic CVD. It's important to note that they don't make any recommendation as far as the specific risk score in which it's appropriate. They say for all patients greater than 50. Conversely, the European Society of Cardiology actually does not recommend any antiplatelet therapy in individuals who do not have cardiovascular disease, and they specifically reference the increased risk of major bleeding, so a little bit of a different recommendation. And then American Diabetes Association, who just had their guideline update this year, do actually recommend aspirin therapy in their diabetic patients who are 50 or more years old and who are at an increased risk of CVD. So they specifically mention certain things that make patients at a higher risk. I like to think of it with the acronym FLASH. So either a family history, L standing for lipids, which are elevated, A for albuminuria, S for current smoking, and then H for hypertension. So if they have any of those risk factors, we would consider aspirin in those patients. So for our first knowledge check, current guidelines support the use of aspirin for which of the following indications? So we have A, primary prevention of CVD, B, secondary prevention of CVD, C, all of the above, or D, none of the above. So how many people think A? B? C? And D. All right, I saw a few hands. So C is actually the correct answer. Once again, secondary prevention has a lot more literature supporting it, and we can all think of specific guidelines that will recommend aspirin. For primary prevention, even though sometimes the data may disagree, those specific guidelines I just referenced, some of them do still advocate for aspirin use for primary prevention. So overall, when considering all the data we've looked at so far, it's once again kind of a balance of the risk versus benefit. So benefits of aspirin from previous trials have been modest. We've seen a relative risk reduction in non-fatal MI by about 22% and all-cause mortality by about 6%. However, this is really counterbalanced with those associated harms, an increase in both GI bleeds and hemorrhagic stroke. So it really leads to the question that in order to overcome this increased risk of bleeding, what cardiovascular risk must our patients have so that the mortality or the reduction in events will overcome that bleeding risk? So when considering the groups that have been observed previously in these meta-analyses, and these were published in 2016, baseline CVD risk in all of the groups actually varied greatly between the different studies. So study participants had anywhere from about a 3% CVD risk over 10 years in one study to greater than 40 in another. So it's really hard to understand exactly what patients would benefit since those risks varied so greatly. And then a lot of the included trials, as we can see, are decades old. So of course, at that point, there were less stringent recommendations about lipid-lowering therapy, antihypertensives, and increased incidence of smoking. So it's hard to really know if the data that we got from those trials really corresponds to our contemporary patient population. So because of that, 4 newer trials were really designed to include individuals that do have a higher risk of cardiovascular disease. ARRIVE specifically looked at patients with moderate CVD risk, or attempted to, as we'll get to in a little bit. ASPRI was looking specifically at healthy patients who are of advanced age, so once again, another risk for increased cardiovascular disease. And then both the ASCEND and the ACCEPT-D trial were looking at patients who had diabetes. So there weren't too many trials done specifically for our diabetic patients, so we wanted to use these trials to really look at the evidence for them. So the first trial we'll look at is ARRIVE. This was published in Lancet this year. It was a randomized, double-blind, placebo-controlled, multi-center study. It looked at a little over 12,000 patients who had moderate cardiovascular disease risk, and this was included from over 500 study sites. The intervention was either 100 milligrams of aspirin or placebo daily, and average treatment duration was about 5 years in these patients. Specific inclusion criteria, male patients had to be 55 years or older with 2 to 4 CVD risk factors. Female patients were a little bit older with 3 or more CVD risk factors. And on the next slide, we'll get into what those specific risk factors were. And then specific exclusion criteria were any history of a vascular event, required antiplatelet or anticoagulant therapy, a high risk of GI or other bleeding, as well as diabetes. So this trial did specifically exclude any diabetic patients. They felt that there were a lot of factors that went into the use of aspirin in these patients, and they chose to not study those patients. For risk factors, patients who had high cholesterol, regardless of current treatment, so that was defined in men as total cholesterol greater than 200 or an LDL greater than 130, and for women, those values were a little bit higher. Any history of smoking in the past 12 months, HDL less than 40, systolic blood pressure greater than 140. Any patients who were taking a medication to treat high blood pressure were also considered at risk, and then any patient who had a positive family history of CVD. And then based on these risk factors, and they also calculated associated ASCVD risk scores, patients had 10-year risks of anywhere from about 10 to 20%, which the study group deemed to be a moderate risk of CVD. So the primary endpoint was a composite endpoint. It looked at the time to the first occurrence of several events, so myocardial infarction, stroke, cardiovascular death, unstable angina, or TIA. And then they also looked at safety endpoints of the incidence of hemorrhagic events, as well as incidence of all other adverse events. So first, just looking at baseline characteristics, a few things to point out is that the study population was predominantly white, 98%. They had a pretty normal body mass index, which sometimes limits applicability to a lot of patient populations. And then as you can see, the calculated ASCVD risk score in these patients was about 17%. And now the characteristics shown are for the aspirin group specifically, but they didn't differ between either of the groups. This chart looks at the results of the study. So due to a high termination rate, there was actually about a 30% proportion of patients in both groups who stopped taking the study drug for one reason or another. The authors decided to do both an intention to treat and a per protocol analysis. So as you can see in the intention to treat and the per protocol population, there was no significant reduction in our primary outcome. So the authors concluded that for overall events, there was really no reduction for aspirin for primary prevention use. However, when looking specifically at the per protocol population, we did see significant reductions in the aspirin group in both non-fatal and all myocardial infarction. So once again, because it's a per protocol population, we have to think about generalizability, but it's interesting that when we look specifically at patients who were taking the study drug, we did see some of those similar results from previous studies. And of course, as shown before, rates of GI bleeding were significantly higher in our aspirin groups, and rates of other adverse events were similar between the two groups. One really important thing that was pointed out by the study investigators was that the calculated ASCVD risk score for both groups was about 17%. However, when looking at our intention to treat population just in the control group, our baseline event rate was about 4 to 4.5% for our CVD events. Now, of course, this trial was only done over about 60 months, so even when corrected to a 10-year risk rate, it was still much lower than was expected. So this is when the study investigators realized that using this ASCVD risk calculator in order to get maybe moderate patients of moderate CVD risk, it was actually overestimating their overall risk based on the event rate in our control group. So because of that, the authors concluded that the role of aspirin in primary prevention for patients of moderate risk really couldn't be assessed, since this study was more representative of a low-risk population. And this really kind of shows the challenges of conducting a lot of contemporary primary prevention studies. So there's a wide array of different therapeutic interventions that patients can be on, whether it be statins, antihypertensives, anti-diabetic agents in our diabetes population. And overall better management of blood pressure, dyslipidemia than, say, 10, 20 years ago might mean that our patients are at a lower baseline risk of CVD events. And there's been a lot of studies that have really looked into whether or not our ASCVD risk calculator overestimates the risk in these patients because a lot of this data was from these previous trials. So it's something to consider going forward when looking at other trials. So for our second knowledge check, when taken for primary prevention of cardiovascular disease, aspirin has shown the most promise in reducing the incidence of which of the following outcomes. So we have gastrointestinal bleeding, hemorrhagic stroke, ischemic stroke, or non-fatal myocardial infarction. So who thinks A? B? C? And D? Correct. Yes, so this was from the meta-analysis presented earlier as well as this specific trial. We're really seeing that if we do have a reduction in CVD events, we're noticing it in that non-fatal myocardial infarction. So the next trial we'll look at will be ASPRI. So this was aspirin in reducing events in the elderly. And this was a trial that was conducted and actually the results published in 3 separate papers in the New England Journal of Medicine. And I believe the authors chose to do this just because for each of the separate papers, there were some pretty major findings. So this was a randomized, double-blind, placebo-controlled, multi-center study, just like the last one. And it looked at about 20,000 healthy elderly participants, either from the United States or Australia. And the intervention, once again, was 100 milligrams of aspirin or a placebo daily. We had an average duration of follow-up of about 4.7 years in this patient population. Inclusion criteria, patients had to be 70 years or older or 65 years or older, specifically for any Black or Hispanic patients in the United States, just due to a higher baseline risk of CVD. Patients had to be free from cardiovascular or cerebrovascular disease. And then the patients also had to be free from any chronic illness that would limit their survival throughout the study. Specific exclusion criteria were a clinical diagnosis of dementia. So as we'll see, one of the primary outcomes they looked at did include dementia, which was pretty new as far as terms of studies of primary prevention with aspirin. Patients also could not have a high risk of bleeding, so that includes being on concomitant anticoagulants or and other antiplatelet agents. And then specifically, patients with elevated blood pressure were also excluded. So our primary endpoint for the ASPRI study was disability-free survival. So this was reported in its own paper. And this really was a unique endpoint that looked at a composite of the first occurrence of death, dementia, or persistent physical disability. So this was defined as any disability that inhibited a patient from doing any of our 6 main activities of daily living. Our secondary endpoints were all the individual components of our primary endpoint, as well as fatal and non-fatal cardiovascular disease, fatal and non-fatal cancer, and then major hemorrhage. Baseline characteristics of all the patients included are here on this chart. Once again, aspirin group is shown, but there was no difference between the 2 groups. We have another patient population that was predominantly white, a little over 90%. These patients also had a body mass index of about 28, so a little bit lower than some might expect, especially here in Tennessee and the South in general. And then previous regular aspirin use was actually not a specific exclusion criteria, but the amount of patients who had been previously using aspirin regularly was the same in both groups at about 10%. So in the first published paper looking specifically at disability-free survival, we saw that aspirin had no effect on this primary endpoint. So the results were not different between either of the groups. The trial was actually terminated early at 4.7 years after the investigators realized that aspirin would really confer no additional benefit in these patients. Adherence rate in this study was about 63%, so about what we think we see in our regular patient population. And then simply living longer is not always what we want to see in our patients. So that's why the study investigators specifically looked at disability-free survival. They wanted to see that just because these patients were living longer, was aspirin actually improving the quality of their life? And these results show that there was really no difference. The second paper that was published looked specifically at cardiovascular events as well as rates of bleeding. So for all of the endpoints that were studied regarding cardiovascular events, there was really no difference, once again, between our 2 groups. So just like in ARRIVE, the rate of our cardiovascular events in our control group was a lot lower than what was predicted. Study investigators expected to see, just based on some risk calculations, about a 22% ASCVD risk. However, patients were closer to about a 13% risk. So higher than our previous study, but still not what they expected, which once again goes along with that possible overestimation by these calculators. And then once again, when looking specifically at bleeding, patients in the aspirin group did had significantly higher bleeding events. One thing to point out is if you look specifically under extracranial bleeding, gastrointestinal bleeding in general accounted for about half of the bleeding events, with specifically upper GI bleeding accounting for about a third of total events. So the higher risk of upper GI bleeding, because it was so pronounced, the investigators were wondering, if there's a way that we could possibly mitigate that effect in our patients. So discussion of possibility of PPI usage or something of that sort, but a lot more studies need to do for long-term safety data. But once again, just showing that whenever we're thinking of adverse bleeding events of aspirin, those GI bleeds are really the ones that are more pronounced. And then the last published paper looked specifically at all-cause mortality. This was actually a really interesting finding, and I think what prompted this to also be published separately. So both all-cause mortality and cancer-related mortality were significantly higher in our aspirin groups. So this was a groundbreaking finding. This was never shown by any previous studies, and it contradicts a lot of the findings of previous meta-analyses, specifically for the incidence of cancer. So aspirin's also been thought to be preventive of cancer, specifically colorectal cancer. So this finding of an increased risk of cancer was quite startling to the study investigators. However, it's important to note that the median follow-up of these patients was about 4.7 years. So the results seen with prevention of colorectal cancer, we really don't see these until about 10 to 20 years of treatment, or at least based on what previous studies have shown. So the authors concluded that both the increased mortality and the increased cancer-related mortality should really be interpreted with caution because it was kind of a new finding. So in conclusion, the risks of bleeding greatly outweighed any potential protective effects, specifically when looking at our healthy population. Due to the low number of non-white study participants, of course, we have to worry about applicability of these results. And then one thing that the trial authors did mention, because about 10% of both groups were previously taking aspirin before they were admitted to the study, the trial didn't directly address whether or not, if we don't think patients need to be on aspirin, should we discontinue it? So I think that's something that further studies could look into. It makes sense that we would want to, especially in these elderly patients with their increased risk of bleed, but that's something that I think more research needs to be done on. And then the last study we have is the ASCEND trial, or at least the last published study. And this looked at effects of aspirin for primary prevention in our diabetic patients, with ASCEND standing for a study of cardiovascular events in diabetes. So this was another trial that had a similar study design. It looked at a little over 15,000 diabetic patients from the United Kingdom, and our similar intervention was shown, either 100 milligrams of aspirin or placebo daily. Average duration of follow-up in this trial was about 7.4 years, so a little bit longer than some of our previous trials. Something else important to mention about ASCEND is patients were also assigned randomly to receive 1 gram capsules of omega-3 fatty acids daily as well. So they were attempting to do a 2x2 factorial design. However, the results of that specific intervention were for another paper that was to be published. In ASCEND, we specifically were looking at patients who had taken aspirin. Randomization between the two groups, whether they were receiving aspirin or not, was similar for our omega-3 fatty acids. Inclusion criteria, of course, we were looking at diabetic patients. They had to be 40 years or older, and they had to be free from any overt cardiovascular disease. Specific exclusion criteria were any clear indications for aspirin in these patients, as well as any contraindications to aspirin in these patients. And then also looking once again at making sure patients were taking the study drug, if patients had any other conditions that would limit their adherence to the trial regimen that they were given. The primary endpoint was the time to our first serious vascular event. Vascular event was a composite of non-fatal MI, non-fatal stroke, TIA, or death from any cardiovascular cause. Secondary endpoints were the first occurrence of any major bleeding event for safety purposes, as well as the incidence of GI tract cancer, once again looking at that colorectal cancer reduction or possibility of it. And then as well as a composite of both any serious vascular event or any arterial revascularization procedure. Baseline characteristics of this study group are presented here. So in this case, once again, predominantly white patient population. Body mass index was higher, which is a little bit better for our diabetic patients because I'm sure we can all know when we see our diabetic patients in the hospital, we usually see a larger BMI. One thing to mention about diabetes is when looking at the baseline A1C for these patients, a little over 50% of the patients had an A1C of 8% or less. Though 37% of the patients, the A1C was unknown, this really shows that there's a possibility that these patients had pretty well controlled diabetes, at least, speaking comparatively. So for our primary outcome, looking at our first serious vascular event, it actually occurred in a significantly lower proportion of patients in the aspirin group. One thing that's important to note, and you can see with the arrow here, the study investigators noted that this was most pronounced for the first 5 years, and then it kind of leveled off. But this is one of the few contemporary trials that actually showed a reduction in these vascular events. Study adherence to our assigned regimen was 70%, so this is a little bit higher than previous trials. One important thing to note is that for the trial, there was an 8-week lead-in period, so any patients who did not adhere to a pre-specified amount of doses were excluded from the trial. So once again, we have to think about generalizability to our general population if they're going to be taking aspirin every day or not. This right here looks specifically at the primary and secondary outcomes. First, I'll look at the bottom, just at major bleeding. Once again, not surprisingly, we did have an increased risk of major bleed in the patients treated with aspirin. But another important thing to look at is looking specifically at vascular outcomes. Early in trial recruitment, the investigators actually added TIA as one of the composite outcomes for our primary outcome, just to increase the statistical significance of the trial, as well as the power of the trial. So it's important to note that if you look at the lower box, the significant reduction is whenever we look at serious vascular events that include TIA. However, when you look at the upper box, when we exclude TIA, that significance seems to disappear. So of course we don't have a p-value going along with this because this couldn't be specifically evaluated, but it's just something worth thinking. They increased the trial, that's why they increased the power of the trial. That's why they added TIA as one of the specified events. But wondering if that might have changed the results of the study overall. So in conclusion, the authors said that aspirin use did prevent serious vascular events in our diabetic patients. However, once again, as we see time and time again, it came at the risk of a significantly increased major bleeding risk. These results actually do not support hypotheses that patients with diabetes have a resistance to aspirin. So there's been some data out there that patients with diabetes have an increased platelets, increased platelet activity, and it was hypothesized that possibly aspirin would be less effective in these patients. However, the author said that the results of this study kind of contradict that. So the last trial to look at is our ACCEPT-D trial, and this is actually currently ongoing trial. It has not been published yet. And this is a prospective, randomized, open-label, blinded endpoint, or a probe study. So this is actually a novel design for interventional studies. And an advantage is that because it's open label, it can come at a lower cost and it's more representative of our everyday practice when looking at patient outcomes. And our endpoints, they're evaluated by a subcommittee for which randomization is blinded. So it kind of decreases risk of bias in that respect. And it's thought that because of these interventions and the specific trial study design, there would really be no difference between this and a randomized controlled trial. So it's kind of a novel thing that I thought was interesting to talk about. As far as intervention, Accept D is looking specifically at whether adding aspirin to lipid-lowering therapy has any additional benefit in reduction in CVD events. So once again, with our contemporary patients, we're seeing a lot more of them who are on statins and antihypertensives. So it leads some to believe that it might not be the aspirin that's reducing CVD events. It might be these statins or these other medications the patients are on. So for a primary objective, the investigators will look at the incidence of major vascular events. This graphic is just kind of an overall representation of the trial design. So you can see that patients first will attempt strategies to optimize control of their CV risk factors. So whether that's with diet, blood pressure control, smoking cessation, they will attempt to do that before randomizing the groups, just to make sure we minimize any other baseline CVD risks. After that, patients will be randomized to receive either simvastatin plus aspirin, 100 milligrams daily, or simvastatin alone, and then they'll be evaluated for our endpoints. So this trial was originally slated to end in about 2015, and I'm just realizing, sorry, the reference at the bottom, that should be 2007. This wasn't published in 2017. So it was originally slated to end in 2015, but as of now, no results have been published, so we are anxiously awaiting the results of this study. So for our final knowledge check, which of the following statements is correct regarding the use of aspirin for primary prevention of cardiovascular disease? A, evidence is strong suggesting that the benefits outweigh the risks in all patients, regardless of CVD risk. B, evidence is strong suggesting that the risks outweigh the benefits in patients at low, medium, and high risk of CVD. C, evidence is insufficient to determine which patients would experience greater benefit than harm. Or D, evidence is strong, suggesting that the decision is highly individualized and must consider the risks and benefits of therapy. Sorry, that was a mouthful. So how many think A? B? C? And D? Great. So I saw a lot of people answer D, which is correct, but I also believe C is correct. So we've had a lot of trials that have looked specifically at patients, and we've known that if patients are at a higher risk of CVD, we could assume that aspirin would have maybe more of an effect on reduction in CV events, but we just haven't had a well-designed trial that's really shown that. So I think it's really we have insufficient evidence to say this particular patient population is at greater risk, so that will outweigh the risks of bleeding in these patients. And then, of course, as we spoke about early in the presentation, it is a highly individualized decision, and we have to consider risks and benefits in our patients. When looking at our evidence, we have to think about the fact that a lot of our CVD risk calculators may overestimate this risk, and we do have some guideline recommendations that specifically utilize this risk to recommend aspirin. We also have to think about patients being on other therapies that reduce CVD risk, like their statins, antihypertensives, and deciding whether or not aspirin confers any additional benefit. So I think additional trials should be done to investigate that, like the Accept D trial. And then lastly, we have to take our patients into consideration as well. So patients have to understand that, just because you can get baby aspirin over the counter doesn't mean that it's, a benign drug. We have some pretty hard-hitting evidence that the bleeding risks are significantly increased, especially in our elderly patients. And then though our guidelines do kind of aid in decision-making, it really has to be a more individualized decision that includes talking to the patient and them understanding the possible risks. So with all that, these are my references, and I will now ask for any questions that anyone has. Yes, sir.
So most of the newer trials with the monoclonal, we would get 50%.
Right.
So can we
Right. I think that's a good question. I went into it assuming that that 100 milligram dose is pretty representative. I think I took that mainly from looking at the ADA guidelines, so recommending that median between 75 and 162. So I believe we can extrapolate it. I think especially considering that those very early trials looked at really higher doses of aspirin and we still saw the benefits, I think that using that lower dose as opposed to 100, we wouldn't see a difference in benefits. As far as bleeding risk, that I'm not completely sure of, but I would assume it would be pretty similar. But that's a good question. Any other questions? I saw your hand first.
Looking at the exclusion criteria for some of these trials,
Mhm.
and primarily looking at the safety endpoints,
Mhm.
are there any patients that you recommend stopping aspirin?
Especially from a hospital standpoint, I feel like if they're taking aspirin for primary prevention and they're admitted, that's one thing I usually like to look at if they have aspirin as a home med. Because a lot of times, once again, this is an OTC medication that maybe their doctor actually didn't discuss with them taking. They're just taking it of their own accord. So I would almost go to stopping it in all patients who are taking it for primary prevention. We have to think about a lot of our patients being on DVT prophylaxis, which can increase their risk of bleed. So I think that the evidence regarding the benefits really isn't strong enough that I would say stopping it for a few days or so while they're in the hospital would really put them at a higher risk. Did you have a question?
You know, a lot of your data showed that aspirin's a very individualized therapy, or at least it seems that's where the data is going towards. Did you come across anything or anywhere that talked about in your research about pharmacogenomics and what role it may play in aspirin therapy?
No, I didn't, but I probably should have. I know that they were looking specifically at, with like disease-related concerns. There's also some evidence out there that there's a possibility that patients with higher body weight might not respond as well to aspirin. But as far as genetics specifically, I didn't see anything. Is there anything that you know of?
No, I know there's been more and more research into that. We don't have anything kind of well developed out there yet, but it seems to be that that's the way medicine's going. So I didn't know if when we were looking if they specifically pointed to that or if there's trials that are starting to look into that more specifically.
No, nothing that I saw, but it would be interesting to look into. All right, thank you guys.